Assalamualaikum, learned audience. I'm Dr. Afroza Ahmed, and I'm here with my case. My topic is FFR, an excellent tool to decide wisely. So, by seeing the topic now, it is quite sure that I am here with the coronary physiology. So, before jumping to my case, I would like to say a little bit about the coronary physiology assessment and its importance. FFR has become the gold standard for invasively assessing the functionally significant coronary artery disease. FFR and other non-hyperemic pressure ratios guide revascularization in patients with coronary artery disease. Pressure distal to the lesion and pressure proximal to the lesion is assessed with a special wire during the maximal hyperemic state. FFR uses adenosine to induce hyperemia, but IFR, it is more physiological and assess the wave-free period where there is maximal hyperemia and minimal coronary artery resistance during the diastole. Newer indices like DFR, DPR, RFR, they uses the same mechanism or same physiological assessment like IFR, and they have been proven non-inferior to IFR in different observational studies. So this is the cardiac cycle, and we see here FFR assess the whole cardiac cycle, and DFR, IFR, they assess the specific period of the diastole when there is maximal hyperemia and minimal coronary artery resistance. These are the different names from different vendors regarding the same physiology and same mechanism using the IFR. We see the cutoff values here. The FFR has the cutoff value less than equal to 0.8. So lesion having the FFR less than 0.8 would be considered as functionally significant and should be intervened. And other resting indices like CFFR, IFR, DFR, they have almost the similar cutoff values and they are non-inferior to each other. So these are different studies and trial. These are just to assess that, like the defer study, we can defer the patient with non-significant FFR safely without doing the coronary intervention. The FAME trial about the multivessel coronary artery disease, here we can assess which vessel is culprit and we can stent that and avoid multiple stenting. And the defined flare tire and the IFR sweetheart tire, these are studies that prove that FFR, DFR, these is non-inferior to FFR, IFR. So my case, a 63 years old gentleman, he was diabetic and hypertensive, presented with a history of effort intolerance during moderate exercise for last 6 months. He do quite a regular physical activity. He do walk and sometimes do light physical exercise. He had no complaint. But while doing moderate exercise like walking the stairs, he is feeling just a little bit of tiredness during the exertion. His ECG, echocardiography, and other lab investigation really revealed no abnormalities. And during ETT, he could achieve a quite good med, and but he had some STT change, so he was concluded as ETT positive. Coronary angiogram was done. CT coronary angiogram was done, and it revealed that he had extensive calcification, and he was advised to do invasive angiography, and he came to our center. So this is the picture of the left coronary arteries. You can see the vessels are calcified, but there is not that much of significant coronary stenosis in the left system. Then we go to the right system, and here we see the proximal RCA is showing a lesion which is of looking like an intermediate severity and extensive calcification. This is the still picture in this point. What we are going to do? Are we going to jump to the stenting from this point, or are we going to assess more? Are we going to use the physiology? The patient was a doctor himself, and patient was residing in USA. From USA, he came to here with this CT angiography report, and angiography was done in our lab, and patient was also quite aware about his condition. So we decided to assess for coronary physiology. Here we see the Agatston score was very high, calcified coronaries, both left and the right part, and see Here we first did the DFR in our lab, and DFR was 0.92, which was more above the cutoff value, and already proven that the coronary lesion was not that much significant. We can spare the patient for more confirmation, and we are going to spare the patient from stenting. So more confirmation, more safety, we do go for FFR. And here we see the FFR was also not significant. So at this point, we could defer the patient from stenting, and we could safely discharge him with optimal medical therapy. So take-home messages are: assessing coronary physiology is an important aid to avoid unnecessary intervention, especially for coronary lesion with intermediate severity. Deferring PCI versus performing PCI in stable coronary lesion didn't show significant difference in all-cause mortality, event-free survival for future or MI in between two groups. And lower MACE rate and resource utilization has also been established in trials for multivessel PCI, well guided by FFR. FFR is the gold standard, but other non-hyperemic pressure ratios like IFR, DFR, DPR, etc. are non-inferior to FFR, which has been established through different observational studies. Due to added cost of the procedure, it has not been yet that approachable for many patients. Thank you.